Bismillahirrahmanirrahim. I'm going to present the TOG guideline about surgical causes of acute abdominal pain in pregnancy. It's in fact the TOG guideline which was published in 12th June 2018. Okay, I'm going to explain the salient feature of this guideline. So first of all, let's come to the introduction part of this guideline. And in the introduction, the important thing which are written is that the incidence of acute abdomen during pregnancy is 1 in 500 to 300 and 635 pregnancy. Okay, and a structural approach is required to assess patients with abdominal pain in pregnancy that both considers and has the ability to exclude the full range of potential differential diagnosis. Okay, and then it's written that abdominal pain in pregnancy requires thorough evaluation. Although the cause is frequently found to be non-significant, serious life-threatening pathology can occur and can present both insidiously and atypically. And table 1 lists the differential diagnosis to consider. We need to go to the table 1. Okay, this is the table 1. Okay, first of all, let us discuss the table 1, then we will come toward the history points. Okay, differential diagnosis of abdominal pain in pregnancy. We have certain obstetrical causes, we have certain non-obstetrical causes. So among the obstetrical causes, the causes related to the early pregnancy are included, and in those we can include the miscarriage, the ectopic pregnancy, acute retention of the urine, okay, and associated with the retroversion of the uterus, fibroid and round ligament pain. Okay, so these are the common early pregnancy diagnosis. The late pregnancy diagnosis include abruption can occur, patient can go in labor and preterm labor, uterine rupture, acute fatty liver pregnancy, pre-eclampsia, hemolysis, which is elevated liver enzyme and low platelets count, chorioamnionitis, symphysis, pubic dysfunction, and fibroid degeneration, both early and late, and Braxton Hicks contraction. So these are the late pregnancy causes. What are the non-obstetrical causes? The non-obstetrical causes include certain surgical causes which may occur, which may come in association with pregnancy, and those include appendicitis, biliary colic or cholecystitis, pancreatitis, peptic ulcer disease, bowel obstruction, ureteric obstruction, aneurysm, rupture. Non-surgical causes include pyelonephritis, inflammatory bowel disease, ovarian cyst, accident, torsion, hemorrhage, rupture, constipation, trauma, domestic violence, which can be assault, and psychogenic pneumonia, and other rare causes which include myocardial infarction, diabetic ketoacidosis, and porphyria. Okay, so we have certain surgical causes, certain non-surgical causes which are included in the category of the non-obstetrical causes. Okay, now how can we take the history? First of all, we have to evaluate the presenting symptom to refine the differential diagnosis. Secondly, we have to assess the post-obstetrical history, post-medical history, surgical history, and the family history. Okay, it's important that you should not forget to inquire about the trauma, including the domestic violence. The history of abdominal pain should include, like any other type of pain, it should include the site, including radiation of the pain to the other sites, the quality, duration, and timing of the pain, exacerbation and relieving factors, associated symptoms. Okay, and site and radiation of the pain is also important. Ask the woman to indicate the site of the pain. If it is local, then she points to the origin of the pain with one finger, and sharp, this is more aggressive of, if it is sharp, it is more aggressive, so, or more suggestive of peritoneal pain. A visceral pain history is often described as segmentalized or poorly localized. It is clinically useful to differentiate a history of peritoneal or visceral abdominal pain. This can indicate the underlying etiology, though be aware that in the various disease process, depending on the timing of presentation, a visceral, peritoneal, or mixed history may be given. Okay, now coming toward the box 1, in which we are shown the clinical red flags. Okay, require the senior clinician evaluation if we are having certain red flags, and those include readmission or multiple admission, repeated doses of opiates given for analgesia without a cause for pain being established, and the new onset anxiety and confusion being attributed to the psychiatric cause rather than underlying or undiagnosed organic disease. Okay. Now, other important things which are written is that, as suggested, visceral pain originate from the injury to the hollow viscus, which are in fact the tube-like structures. Pain related to the foregut visceral structures, which are mouth to proximal duodenum, including the bladder, is generally felt in the upper abdomen, while that associated with the midgut structures, distal duodenum to the mid-transverse colon, is felt around the umbilicus. Hindgut structure remaining colon and rectum pain is generally felt in the lower abdomen, and shoulder tick pain is associated with diaphragmatic irritation, for example with hemoperitoneum or following visceral content leakage from the perforation. Now, the quality of the pain is also very important. We should ask about it. So, colicky pain occurs as a consequence of the partial or complete obstruction of the hollow viscus, for example, the ureter, biliary duct, or the bowel. The history is often waves of the pain coming and going or increasing and decreasing in intensity. Burning pain that radiates retrosternally is often indicative of peptic ulcer or gastroesophageal disease. Pancreatitis can also present as retrosternal pain. Constant pain that is focal or generalized indicate peritoneal inflammation, and there are multiple causes, but all require early initiation of the appropriate treatment. Now, coming toward the duration and timing of the pain, a sudden onset of the pain should raise a suspicion. However, many of the surgical differential diagnoses to consider have initially more insidious history. Pain may change in site or severity over time. This can provide the important clues as to the underlying differential diagnosis and to progression of the diagnosed surgical condition. This underlines the importance of the regular patient re-evaluation. Now, coming toward the exacerbation and relieving factor. No different disease process for the different disease process, the pain may be modulated by the certain action. Patient reporting visceral pain often describe restlessness, while those with a partial injury or irritation describe the movement as exacerbating the pain. This may help to determine the differential diagnosis if reported, but the absence in the history may not add to the clinical assessment. Now, coming toward the associated symptoms. Eliciting a history of associated symptoms, specifically including their temporal relationship to the abdominal pain episode, can be relieving. The surgical differential diagnosis for abdominal pain may present with other gastrointestinal or urinary tract symptoms about which the clinician should inquire. As described for the first specific surgical condition listed in the table, we will discuss this later. The presence of these in the abdominal pain history may evolve and can aid refinement of the differential diagnosis. Examination is very important. In general, because patient is in pain, it's a sort of emergency, we have to follow the primary survey following the advanced life support ABCDE approach, which is airway, breathing, circulation, disability, and exposure approach should be taken. Okay, and pregnancy specific consideration. Okay, as she is pregnant, so we have to give pregnancy specific consideration, and we have to keep in our mind the physiological changes that take place in the pregnancy. Total blood volume increases by approximately 40% above the non-pregnant levels. Cardiac output increases because of 10 to 30% rise in the stroke volume and a rise in the resting heart rate from the normal 70 beats per minute to 80 to 90. Okay, so 10 to 30% increase in the stroke volume and about 10 to 20 beats per minute increase in the heart rate. So that in turn increase the cardiac output. Changes to the respiratory system are less marked. However, metabolic rate increases, leading to increase in oxygen consumption of about 20% with a slight rise in the basal body temperature as a byproduct. To meet the increased oxygen requirement, ventilation increases by 40%, which is physiological hyperventilation. But there is no change in the vital capacity or respiratory rate. Okay, pregnant women breathe more deeply and increasing their tidal volume from 500 to 700, thus increasing the respiratory capacity. These physiological changes in pregnancy means that there is often poor correlation between the clinical sign associated with the blood loss and the degree of the hypovolemia, because the pregnant women are known to compensate for a relatively long time before becoming symptomatic of the blood loss. Mild tachycardia, tachypnea, narrowed pulse pressure, and agitation are the early sign of hypovolemic shock. Fall in the blood pressure is a late sign. Assessment must consider the fetal well-being as well as maternal well-being by either fetal heart auscultation or cardiotocography, depending on the gestation. Fetal compromise demonstrated by either modality may suggest serious maternal pathology and needs for maternal resuscitation. Now this is the table 3, which is very important, in which all the clinical presentation of the surgical causes of the acute abdominal pain are discussed. Okay, so first of all, the first condition is ruptured or leaking abdominal aneurysm, which may occur in association with the pregnancy. In that, what is the clinical presentation? History may vary depending upon the site, nature of the blood loss. The most acute rupture can present as an unexplained collapse that may be preceded by severe abdominal or back pain, typically intrascapular pain. Pain may also radiate from abdomen to the back or groin. Be wary of the urinary symptoms, including dysuria and microscopic hematuria in patient with aneurysm. History or risk factors for aneurysm such as Marfan syndrome may be there. Okay. The other condition is appendicitis. What happened in that? This type of pain is acute or gradual in onset, colicky periumbilical pain that then localizes to the right iliac fossa. A retrocecal or pelvic position appendix may present atypically with either primarily urinary symptoms or pelvic pain. A gravid uterus can also displace the appendix, so the pain may be described in the right upper quadrant. The presence may progress with appendiceal perforation to more generalized peritonitis. There is a frequent association with the nausea, vomiting, and anorexia. The other type of pain is biliary colic or acute cholecystitis, which is in fact the acute or gradual in onset right upper quadrant or epigastric pain, often worsened by eating. Although the term colic is often constant but remits after a period of minutes to hours. This may radiate to back or flank. Focal tenderness is more prominent with progression from biliary colic to cholecystitis. Clinically eliciting Murphy sign tenderness is increased on inspiration, while palpation in the right upper quadrant is highly suggestive of diagnosis. Bowel obstruction. Bowel obstruction may present with any condition of the colicky pain, nausea and vomiting, abdominal distension and constipation, or absolute constipation, which is inability to pass flatus. The history can vary depending on the completeness and site of obstruction. In the same bowel obstruction, other things which are explained is small bowel obstruction commonly initially presents with the nausea and vomiting, bolus, depending upon the site obstruction, and colicky abdominal pain. And the large bowel obstruction commonly initially presents with abdominal distension, absolute constipation, and colicky abdominal pain. Vomiting may be feculent, is the late feature of the large bowel obstruction. Clinical examination may elicit a high pitch or absent bowel sounds. It is important to consider that this may present. Okay, that this may present following episode of biliary colic or cholecystitis. In addition, the history may initially be similar to that of the biliary colic or cholecystitis. Sudden onset of the severe upper abdominal pain that may be eased by leaning forward is typical. Examination may elicit upper abdominal tenderness, and depending on the severity and progression of the disease, hemodynamic shock may ensue. Gradual or acute onset of the retrosternal or upper abdominal pain is commonly reported, and the relationship of this with eating differs depending on whether this is gastric or duodenal disease. Gastric disease worsens with the eating, while duodenal disease improves with the eating. Okay, this is also a very important point. It was all about the peptic ulcer disease, which is gradual acute onset of the retrosternal pain, and it has relationship with the eating. It is important to be aware that following the perforation, depending upon the whether it is onto retroperitoneal or peritoneal space, will determine whether the clinical feature of peritonitis can be observed. Urinary tract obstruction may be caused by obstruction within the ileum, within the wall of the urinary tract, or external compression. Obstruction may be caused by ureteric calculi, although gravid uterus may also be considered, particularly in the second and third trimester, and typically presents with a colicky pain, which often radiates from loin to groin. And the patient may report associated nausea and vomiting, and macroscopic hematuria may be seen on urine analysis. Okay, now coming toward investigation. What investigation would we like to do? First of all, routine observation, which include pulse, blood pressure, temperature, and all the vitals should be checked. Secondly, when there is significant proteinuria is diagnosed. When significant proteinuria is diagnosed, if the urinary protein creatinine ratio is greater than 30 milligram per millimole. Okay, if the urinary protein creatinine ratio is more than 30 milligram per millimole, or if a validated 24-hour urine collection result shows greater than 300 mg proteins, then that is significant. Okay, and biochemical, full blood count, liver function test to determine urea, electrolyte, amylase, and C-reactive protein level can provide the useful information. And it is important to understand that interpretation should be adjusted according to the pregnancy related physiological changes and considered within the overall patient assessment. Now coming toward the um, imaging. The use of the imaging tools such as the ultrasound, computerized tomography, or MRI can aid assessment and management of the patient with a possible surgical cause of the pain. Now the plain chest x-ray, the erect chest x-ray with abdominal shielding can be considered safe. Transabdominal ultrasound is used to assess the viability of the pregnancy, location of the placenta, and to visualize the fibroid or ovarian pathology. The liver, gallbladder, bile duct, and renal tract can also be demonstrated. Now MRI. MRI is preferred because there is no associated risk of ionizing radiation to the mother or fetus, and it has been shown to demonstrate equivalent accuracy in the diagnosis of the non-traumatic pathology compared to the ultrasound and CT. Management. How would we do management? After initial assessment, the patient with acute abdominal pain, resuscitation will be instituted as needed, and the pain relief provided, and non-steroidal anti-inflammatory drug should be avoided. Okay, the assessment of whether any full diagnostic tests are needed will be discussed later. And anesthetic and medical consideration for all acutely unwell patients or where the surgery is considered, optimization of the medical comorbidities can improve the outcome. Obstetricians. The obstetrician is best placed to oversee and coordinate multidisciplinary care. Usually the delivery suite high dependency unit is the most appropriate location for the woman in the third trimester. If operative intervention is needed, women should be informed that although the surgery is associated with a small increased risk of miscarriage 0.7% and preterm labor. Now coming toward the surgical consideration. Surgical priorities. Surgical priorities include the synchronous assessment and resuscitation of the patient following ABCDE approach. Surgical conditions include appendicitis. Acute appendicitis is the most common surgical cause of abdominal pain in pregnancy, affecting 1 in 800 to 1500 pregnancy. It occurs most commonly in the second trimester. Appendiceal perforation is, however, more common in the last trimester, perhaps owing to the stretched peritoneum. Biliary colic or cholecystitis. Physiological changes in pregnancy, for example, cholesterol secretion and supersaturation of the bile can predispose to gallstone formation, which in turn predispose women to the biliary colic and cholecystitis. Cholecystitis is the second most common abdominal surgical pathology in pregnancy, with a 1 in 6 cases in 1 in 1000 pregnancy. Over 90% of the cases are associated with the gallstone disease. Biochemical tests may reveal evidence of the inflammation. Liver function tests are essential to determine whether there is an obstructive jaundice picture. This may indicate an obstructing common bile duct stone, warranting further investigation and treatment. Transabdominal ultrasonography is the initial imaging investigational choice for biliary colic and cholecystitis, with more than 95% sensitivity of detecting gallstone. Biliary colic can be managed with adequate analgesia and antiemetic. Following resolution of the acute episode, definitive laparoscopic cholecystectomy is subsequently required. Initial management of acute cholecystitis involves intravenous fluid resuscitation, analgesia, a nil by mouth regime, and intravenous antibiotic. Urgent surgical intervention is only required if the disease progression with the perforation and subsequent focal or generalized peritonitis. Now, bowel obstruction. Bowel obstruction can occur in 1 in 1500 pregnancy. Colonic pseudo obstruction, sometimes referred to as Ogilvie's syndrome or functional colonic obstruction, can be a complication of the pregnancy and delivery, most commonly by cesarean section. Biochemical tests may be used to diagnose any electrolyte imbalance or renal impairment secondary to hypovolemic shock caused by third space loss. Abdominal X-ray is avoided because of the peritoneal harm to the fetus. Ultrasound and MRI are considered safe. Pancreatitis. Pancreatitis is a rare event in pregnancy, occurring in 3 into 10,000 pregnancies. Serum amylase of more than 3 times the upper limit of normal may be diagnostic. Serum lipase is more sensitive and specific than amylase for diagnosis of acute pancreatitis. Okay, so this is all about the TOG guideline of surgical causes of acute abdominal pain in pregnancy. Thank you so much for your patience.